Dr. Shaina, we can start now, Doctor. It's 6:45 p.m. and the speaker is waiting too. Thank you.
Thank you, Doctor. Good evening, everyone. I know. Am I audible? Yeah. Good evening,
Yes,
everyone,
yes,
and a very warm welcome to all who have joined us today from across the seas. We are delighted to have your presence here for yet another enlightening session as part of our ongoing free webinar series on women and child health. November by the IHMA National Women's Wing UAE chapter under the leadership of our esteemed chairperson Dr. Halloween and convener Dr. Jagati. Today's session promises to be deeply insightful as we explore a topic that touches many lives, ADHD, understanding attention deficit hyperactivity disorder. I am your host for the evening, Dr. Shahina Kadri. I have been practicing homeopathy since last 2 decades and since over 12 years in UAE at Dr. Batra's esteemed organization, and I'm truly honored to guide you through this wonderful learning hour. Let's begin this session on a warm note, and I'd like to invite Dr. Deoshri to deliver the welcome address and with her lovely voice set the tone for today's discussion. Dr. Deoshri is currently practicing as senior homeopathic practitioner at Medicure Clinic, Dubai. Over to you, Dr. Deoshri.
Thank you, Dr. Shahina. Good evening and a very heartfelt welcome to everyone joining us today for this session in the Women and Child Health webinar series organized by the Indian Homeopathic Medical Association, IHMA. I, Dr. Devshri, welcome you on behalf of IHMA National Women's Wing, and it's truly a pleasure to have you all with us. Today's presentation, A Bird's Eye View on Neurodevelopmental Disorders, addresses complex conditions including attention deficit hyperactivity disorder, ADHD, and learning disabilities that require thorough clinical understanding and a multidisciplinary approach. Homeopathy in UAE operates through a regulated healthcare framework embracing a holistic, individualized approach central to its philosophy. Unlike conventional treatments that often target symptoms alone, homeopathy considers the totality of the person's physical, mental, and emotional states, tailoring care to each individual's unique constitution. When considering ADHD, it is important to recognize its distinctive characteristics and potential. As Dr. Russell Barclay, a leading expert on ADHD, famously said, ADHD is not a disorder of knowing what to do. It's a disorder of doing what you know at the right time and places. This highlights the complexity of ADHD and the need for tailored, patient-centered interventions. Homeopathy's holistic model supports this by addressing the entire person's well being, fostering balance and long term improvement beyond symptomatic relief. Furthermore, the IHMA advances this philosophy through continuous educational conferences and workshops, ensuring that practitioners uphold evidence based, individualized, and compassionate care. Thank you all for participation. It is our hope that this discourse deepens our collective expertise and fosters enhanced outcomes for individuals affected by neurodevelopmental disorders. I would now like to hand over to Dr. Shahina to continue with the program. Thank you. Dr. Shahina, you're on mute.
Thank you, Dr. Deoshri, for that gracious and heartfelt welcome. To introduce our eminent speaker for the evening, I now invite our moderator for the day, Dr. Rajeshri Rele. Dr. Rele, our distinguished senior homeopath, has been practicing in Dubai since 1989 and at present holds a clinic at Good Living Medical Center, Dubai. Her dedication and expertise have earned her recognition, including a certificate of appreciation from the Ministry of Health and Prevention UAE. Dr. Rajeshri, over to you.
Thank you, Dr. Shahina, for the kind words. Good evening to everybody. I would like to now introduce our most prestigious speaker this evening, Dr. Salini JP. Dr. Salini JP is an experienced homeopathic physician with over 18 years of independent clinical experience. She is a graduate of the Government Homeopathic Medical College, Thiruvananthapuram, 2008, and she is further specialized in hospital management from Bangalore in 2009. She's also completed her MBA in HR from Pondicherry in 2015. She is the founder and chief consultant at Dr. Salini's homeopathic clinic in Tiruchirappalli, Tamil Nadu. She was awarded the best homeopathic practitioner there in 2024. Dr. Salini is also the co-author of the book Reverse Repertory of the Mind, which is published by B. Jain Publishers and is available also on Amazon. She has also contributed to the IHMA Homeopathic Journal and shares educational content through her clinic's YouTube channel. She's a very dynamic speaker and very passionate advocate for homeopathy. Her mission is to make homeopathy more accessible, accepted, and scientifically understood across diverse patient populations. So over to you, Dr. Shahina, to carry on. Thank you. You're muted, Dr. Shahina.
Thank you, Dr. Rashri, for your precious time and for your wonderful introduction. Before we hand it over to our speaker, let's pause for a moment to reflect on today's theme, ADHD, Attention Deficit Hyperactivity Disorder. ADHD is one of the most commonly discussed neurodevelopmental conditions seen in children. Though it often continues into childhood, it affects focus, behavior, emotional regulation, and sometimes masking immense potential behind layers of restlessness or distraction. Understanding it early and approaching it with empathy, awareness, and holistic strategies makes all the difference, and that's exactly what today's session aims to unfold. So without further ado, it's my pleasure to invite our esteemed speaker, Dr. Salini, to take us through her presentation on ADHD. A very quick note to our audience, kindly type your questions in the chat box during the session. They will be addressed by Dr. Salini towards the end of her presentation. And nevertheless, keep your mic muted, like I kept kept myself muted also. Over to you, Dr. Salini.
Good evening to all of you. Thank you, Dr. Shahina. Thank you, Dr. Deoshri. Thank you, Dr. Rene ma'am. Thank you, Dr. Halloween. Thank you, Dr. Shahina, for the wonderful introduction that you have given. And Dr. Rene ma'am, it's been an honor to have met you even through this platform. And Dr. Deoshri Sharma, you have done a wonderful welcome. Before I move on to the presentation, I would like to say thank you to IHMA National Women's Wing for inviting me as the speaker. I would like to say thank you to Dr. Halvin in special for making this process smooth one. And special mention to my mentor in this field, Dr. Rekha ma'am, who has faith on me. So moving on, myself, you have given all the introduction. As we move on directly to the presentation. Today's presentation is actually Bird's View of Neurodevelopmental Disorders. That means it's basically a big umbrella of disorders. Now, this I have tried my best to make it as packed as possible. So let's move on. I'm going to share my screen. And please let me know whether everything is working smooth from your end, Dr. Shahina.
The screen has started sharing. When it's visible, I will just give you a go.
Yes, is it fine? Yeah.
We can see. Yes, here you go.
Okay. Now, just a second. Let me arrange my slides. Yeah. So basically, it's like I had mentioned, it's a bird's eye view on neurodevelopmental disorders. Myself, my qualification, my YouTube channel ID. If anybody needs to contact and follow me up, it's my WhatsApp number. In case the doubts I'm not able to clear by the end of this session, I feel free to message me and I shall get back to you in due time. Let's start. Let's start, I guess. Okay, Before we start, I would like to play obeisance for our Guru. In our Sanskrit verse, Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Parbrahma, Tasmai Shri Guru Namaha. So for Samuel Hahnemann, because without him we wouldn't be here, we wouldn't be aware of this wonderful science, homeopathy, and its role that is now being appreciated all over in this particular disorder umbrellas. Let's start. I think this screen is it now clear? Is this?
It's clear.
Yeah. Oh, okay. So let's see the overview of neurodevelopmental disorders. Okay, basic definitions wise, we will start. It's more of a theoretical concept that we'll be covering during this session. Fine. So what do you mean by neurodevelopmental disorders? So neurodevelopmental disorders are basically a group of conditions that arise during the development of the nervous system. So basically, from the perinatal stage itself, it has developed. We all know that the nervous system is developing by the 3rd week of the conception. Now, typically manifesting in early childhood, the manifestation may not be immediately once the child is born. It takes time unless and until it is IDD category, but mostly it manifests in the early childhood. So they result in what? In impairments in personal, social, academic, or occupational function due to atypical brain growth, connectivity, or neurotransmission. These are basic terminologies that have been mentioned, basic definition. Now we need to, how it happens is it's not something that you can pinpoint it. That is the beauty or what fault or whatever term you want to use for it. It is not one particular condition that leads to it. So these disorders are caused by complex interplay of genetic, epigenetic, and environmental factors, which often involve disrupted neurogenesis. The terminology neurogenesis, it is neuron synthesis or creation. Now, synaptogenesis, synapse formation, or neuronal migration. It's a migration of neurons to their specified areas. Okay, so when something goes wrong in this pathway, this electrical pathway, there is the whole issue of neurodevelopmental disorders starts. Basically, it has been categorized into intellectual developmental disorder. The picture is almost similar to what the condition is. Autism spectrum disorder, attention deficit hyperactivity disorder, communication disorders, specific learning disorders, and motor disorders. Now, for this particular presentation, I am going to introduce or include epilepsy, which is seen in the NDD, that is neurodevelopmental disorder, because it is currently under ICD-11 category, but is not mentioned under DSM-5 category. However, this is a very frequently researched stuff because it is overlapping. So I'll be discussing that as a part of neurodevelopmental disorder. The footnote is clearly mentioned that it is not at all there in the DSM-5 category because it is clearly mentioned as a neurological condition. However, the neurodevelopmental and neurological overlap is being recognized currently in the emerging research and all. So in ICD 2023 that has been published, the current neurogenic research, genetic research is mentioning it under epilepsy-related NDDs or developmental epileptic encephalopathies. So the same thing which I've explained, what I have written here also, according to DSM-5 neurodevelopmental disorders include 6 main diagnostics, only that I have mentioned. Epilepsy itself is not at all classified under this list. It's categorized as a neurological disorder. But as I said, in recent years, research in neurogenetics and developmental neuroscience, which has shown that certain forms of epilepsy are not just seizure disorders. In fact, they are the one which is causing the disruption of the brain development itself. And therefore, it has been given a terminology as epilepsy-related neurodevelopmental disorders or developmental and epileptic encephalopathies. So this is actually a new one. The classification, diagnosis and all is actually overlapping with the traditional neurological department-wise. And the ICD-11 classification by the World Health Organization now explicitly includes a category called developmental and epileptic encephalopathies, which recognizes this overlap between epilepsy and neurodevelopmental disruption. We'll move on to the causes. Few pointers I'll mention the first slide itself. Let's go in depth. So neurodevelopmental disorders arise from complex interactions, like I mentioned, among genetic, epigenetic, environmental, and neurobiological factors that disrupt the brain growth and circuit formation during the prenatal to early childhood period. Very simple. Now we move on to one by one. What is genetic? So there are inherited or spontaneous mutation in brain development genes. So we all know genetic factors are DNA, gene sequencing, phenotyping. All these factors is a specific code, a specific format has to be followed. So where there is spontaneous, sometimes it happens the genetic gene is being either autosomal dominant or autosomal recessive is being transferred, or spontaneous mutation. While the process is going on, while the fusion is going on, there is mutation happening. This particular CHDH, SHANK3, MECP2, DRD4 are the most commonly seen gene where those sort of mutations are seen. Particularly CHD8 and SHANK3 are like a headquarters. It is a headquarters of these nervous development. So one particular small factor gets mutation happens here, some deviation happens here, some snitch happens here in this particular headquarters. It cascades down to the pathway and causes completely change into the sequencing. Next one is epigenetic, but the change, see, epigenetic, I know most of you know it, but for explanation, it is above genetics. It's like the planner who plans what has to be done, right? So it's like you have genetics, we know what has to be done, what all things is being getting from the parents, we have an idea. But now what the child is going to express, now who decides that? That's the planner. So epigenetics basically means it's above genetics. So the changes, the selection, everything, the gene expression is controlled without any change in the DNA sequences. So DNA sequence remains the same in each cell, but what feature that particular gene will express will be decided under the epigenetic factor. However, any changes, any mutation, any error with respect to the maternal stress, toxins, nutrition, this leads to the disorder stage. Now, neurobiological. So, abnormal brain structure, many conditions we know, many infections we'll be knowing. Delayed myelination. Myelination process usually happens towards the end of the fetal development and continues post-birth also. So any delayed myelination also disrupts the connectivity between the key regions of the brain, frontal, prefrontal, temporal. This connectivity is the whole issue, basically circuit problem. Now, let's move further. Genetic causes. Changes in DNA that affect brain development, which is either inherited from parents or appearing spontaneously, which we can vaguely classify or pointed as 4 different aspects. The first one is single gene mutation, MECP2. That gene is responsible for methylation of the DNA. That is, it causes silencing, regression of if mutation happens. So that leads to a condition called Rett syndrome. FMR1 gene that causes Fragile X syndrome. That is, this particular gene is Fragile X formation, protein formation is required for this female, as it's basically the X chromosome. So basically, it's for the cognitive development and the female reproduction. So when it is affecting the female or the girls, it can be managed. But if the Fragile X syndrome is affecting males, since they have only one X chromosome, the symptoms are more prominent, and the issues of cognitive disorders and motor disorders and all are more prominent in males, especially they have a specific facial structure and all. The third one is SHANK, SHANK3 and CHD8, which leads to not only leads to autism spectrum disorder, many things I have just cited out as the one example. Now we move on to the next point, that is copy number variations. What do you mean by copy number variation? See, we all know when the fusion happens, both parents, one set comes together. Now, when that is normal. Now, sometimes one of the gene gets missing. That is known as deletion. Sometimes one of get excess, maybe 3, 4. That is duplication of the particular gene. Now, there are conditions where particular sequences has been identified, particular code has been identified in the DNA sequence, One of the examples is 22q11.2 deletion, which is more often seen, which leads to intellectual disability and schizophrenia risk. The third factor that can be seen under the genetic cause is the polygenic inheritance. That means this ADHD, this ASD, or SLD often may not result from one particular reason, like I mentioned the first and second point. It could be small variations, but together they form the all these genetic variants work together to cause these particular conditions. And the last, actually, it should be the first one, but I've mentioned the last, the heritability factor. So the ADHD, we get 70 to 80%. ASD, we get 80 to 90%, and learning disorders up to 60%. Now, the epigenetic causes. So, chemical changes that affect gene expression without altering the DNA sequence, often caused by environmental, stress, or toxins. What I explained previously. The mechanism, how it goes. So, these are a few pointers of the epigenetic stuff. One is DNA methylation. That is, like I mentioned in any CP2, genes turns off. This is a very complex process for me to explain in one go. I'll try to explain it as simple as possible. See, a methylation process where the DNA is introduced the methyl group CH4, acetylcysteine, and guanine base. It's in the brain cells near the gene receptor. So, which is where the switches are on and off. Now, this, if there is excess, that is hypermethylation happening, it basically goes off. That is, the gene refuses to transcript, or they do not allow the transcription. So, DNA is getting passed off, but it is in a muted zone. And if it is low methylation happening, then it gets transcripted. So, that balance has to be maintained. So, this factor, DNA methylation, is a very important factor in the normal neural development. So, anything which leads to normal genes getting off due to maternal stress, which leads to hypermethylate dopamine receptor genes, DRD4, and that lead to ADHD. Not only stress, smoking also leads to the same thing. Now there is histone modification. Histones are the proteins around which the DNA wrap themselves. Okay. So now what happened? It gets introduced by acetyl, methyl. These substances get attached to this histone, and then there is this imbalance or mutation that happens. This basically histone modification leads to how the DNA is packed, because if it becomes heavy, the movement and the gene accessibility gets stuck. But the third one is non-coding RNA or microRNAs. What are non-coding RNAs are like DNA basically processes to form a protein. So all those things which are not converted to protein becomes non-coding RNA. So this microRNAs is the most common RNAs that are found, and they fine-tune how much protein a gene makes. Either they block it or they completely destroys it. So this disrupts the neuron signaling. For example, just few examples I mentioned. Considering the table is an environmental factor, epigenetic effect, and the outcome. So if there is a prenatal stress happening, there is usually methylation of HPA axis genes that is seen, and that usual outcomes are ADHD and anxiety. If there is maternal smoking, the changes are seen in dopamine transporter gene, hyperactivity is seen. If malnourishment or malnutrition due to folate deficiency alters the DNA methylation globally. This epigenetic factor is why we give it extreme importance to the prenatal maternal health. All this neural development, all these things that the mother is having, which we know it. I'm just trying to explain it in a more scientific and more biochemical aspect. We know why folate is required. We know why vitamins are required during the pregnancy. We know why good food are required. We know why stress should be avoided, why alcohol, why smoking. But what happens behind that back doors? So that is what is being explained out here. So which will lead to neurodevelopmental disorders. Now moving on, we have environmental causes, basically external conditions during pregnancy or early childhood that interfere with normal brain formation. It's like prenatal factors. I've divided prenatal, perinatal, and postnatal. So prenatal factors, we know maternal infections, rubella, Zika, cytomegalovirus, anything that causes infection, it creates its imbalance. Now, exposure to toxins, lead, mercury, pesticides, If there is alcohol and drug use, we have fetal alcohol spectrum disorders. That's altogether a different disorders category. Then use of certain medication, valproate and topiramate. These two medications usually used for bipolar, epilepsy, and certain psychological conditions also we use. So if the parent is also suffering from neurodevelopmental disorders or any psychiatric diseases, conditions, and the medications are being taken during the prenatal factor, it should be monitored and controlled, or else, or as such, the high risk factor is there. If already the parent is suffering from NDD, the gene will be transferred. But we can monitor it and we can try our best to avoid the severity, or maybe to avoid it completely. Now, chronic maternal stress leads to cortisol overload and fetal brain changes. Okay, now chronic maternal stress is a very important factor, most important of all factors, because that is a very commonly seen condition. Infections we can avoid, exposures we can avoid, alcohol, drug use we can avoid, medication we can avoid. But the one thing that only the mother and the environment around her can be controlled is her stress level. Now moving on, it is perinatal and postnatal factors. Let's take like premature birth or low birth weight. It leads to proper the process or the pathway or the chain of reactions not being properly followed. So that's a chance of neurodevelopmental disorder, which is an environmental cause. Neonatal hypoxia or oxygen deprivation, both types it can happen. It can happen while during the course of birth, during inside prenatal, or even postnatal when the child is not breathing well, has a low birth weight. So somewhere the oxygen is getting deprived. We know how much crucial oxygen at that particular point of childbirth is for the child. Now, malnutrition during infancy, this is post-birth. And early head injury or infections, meningitis, encephalitis. And sometimes the child, injury happens, falls, some hit is happening on the head. So these also lead to neurodevelopmental disorders. Another one is immune dysfunction, that is immune reactions during pregnancy, both maternal and of the developing child, may produce neurodevelopmental disorders. This is PANDA standards. So basically the full form of it will be pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. There has been studies saying that when they have been infected by this, the child was not having any condition. They developed drastic regression, drastic symptoms of neurodevelopmental disorders. So this is under study. And then there is Sydenham, Korea, etc. Also causes are under this immune dysfunction. Now comes to the neurobiological causes. Direct disruptions in how neurons grow, they migrate, they connect and communicate within the developing brain. So neurons grow, neurogenesis is happening, neuronal migration is happening. So how are they connected by synaptic connection, and how are they communicating by neurotransmitters? These things during the process of the normal pathway, any direct disruptions are happening, will lead to the condition. So we move on to the mechanism. There is abnormal neural migration. There is neurons fail to reach correct brain areas. It leads to cortical disorganization. Synaptic dysfunction, weak or excessive neuron connection. Weak, we know, IDD happens. It is, and also seen in ASD. And excessive is also known as ADHD. Now, neurotransmitter imbalance, basically dopamine and norepinephrine causes ADHD. GABA and glutamate causes ASD and epilepsy. So myelination defect, like I mentioned in the first slide, that it usually takes place towards the end of the pregnancy. But when there is defect is happening, there will be slower neural transmission, causing learning delays are seen. Brain regions commonly affected in their role and which all condition could be related. So this is like prefrontal cortex. What is the function? Executive control. When it gets affected, their ADHD usually seen. When cerebellum, that causes coordination and timing, motor disorders. Temporal cortex, language and social cues, ASD, and we have special learning disorders, specific learning disorders. And then basal ganglia, we have motor and reward, Tourette's, and ADHD. Now, psychosocial and environment interaction. and emerging causes under 2025 research focus also be discussed. So it's, let's say, as a two-hit theory, what is psychosocial and the environmental factor in? See, when suppose already a child has a genetic vulnerability, that's the first point. The second, there is an environmental stress. That is the second point. Both of them, when combined, it causes the clinical disorder. For example, a child with DRD4 gene variant has been born, but during the early childhood, there is a neglect, there is an environmental stress factor added. So higher ADHD risk than only one particular factor alone. Another interesting thing which of late which has been under discussion, but of late research has been much promising in the field is of microbiome brain axis. That is a gut brain connection, vagus nerve, hormone that has been synthesized in the stomach, serotonin, the modulation of the hormone by the gut bacteria, the condition that caused by the neurodevelopment disorder that is caused due to leaky gut conditions. These things falls under this category. This all causes neurodevelopment disorder. And also when there is dysbiosis, that is gut imbalance happening, it's usually linked to ASD and ADHD symptoms. So now the next stuff is very, very common. It can happen, but if controlled, it can manage. That's maternal sleep disruption during pregnancy affects the offspring brain maturation. This is not so much prevalent. It's just a new study which I found it quite interesting, which is quite manageable. So basically, things which we can manage during our case consultation, during our when we are having a patient or when we are having a pregnant woman, something which we can control. Like we can't control genetics. We can control epigenetic factors to an extent. We can control certain things like nutrition. We can control their sleep patterns. We can control the stress factors. So this was quite interesting. But if this factor can also be controlled, a more positive or more controlled environment for absence of neurodevelopment disorders we can have. And then mitochondrial dysfunction is also a new later study where energy production defects are linked to motor and learning disorders. So what we have understood so far with respect to the NDDs are, they're not caused by one single factor. They are like a multi-layered cascade of biological and environmental influences that alter early brain development. So genes, epigenetics, the environment, brain circuits, how do we know? We know only through behavior. Move on to the core features of NDDs. So this is basically, I am calm for people, children, students who would like to remember these stuff. So I, intellectual disability, we know it is low IQ plus adaptive deficits. A is autism spectrum, social plus behavioral rigidity. M is motor disorders, coordination and tic problems. C is communication disorders, where language or speech delays are there. A is ADHD, inattention and hyperactivity. L is learning disorders, reading, math, writing problems. And M is mixed comorbid, where I have introduced the epilepsy-related stuff. So where seizures plus developmental delay mixed because see, epilepsy overlaps with ASD, ADHD, multiple neurodevelopmental disorders. So that factor can also be kept in. But epilepsy should be remembered even if it is M. So mixed or comorbid. So it's a very funny anecdote that I'm going to share out here. When I created this I am calm mnemonic, my son came and asked one thing like, Mom, you have just done I am calm for a condition where children are not actually calm. So why have you found out? So it's like more so for the caregivers, like I am calm, I can handle it. For the doctors, for I am calm, I can handle it. We can work together. So that is how I pacified it. But he had a point. This I am calm mnemonic is very oxymoronic for a condition where children are not typically calm. They are in a very out of the box category that we are keeping for. So this is for the children who, or doctors who would like to remember this for any examination purposes also. Now, one by one, we'll move on to it. So, intellectual developmental disorder. Okay, time is running. So, core features, we have cognitive and behavioral manifestation and common comorbidities. What are the core features? So, it's logical, intellectual, developmental disorder. There is deficit in the intellectual functioning, reasoning, problem solving, planning, abstract thinking. These are basic intellectual functions for any person. So, once there is any deficit, it causes. Not only that, it is also adaptive behavior. That is how you behave in the social atmosphere, how you behave in the practical skills, how well are you able to adjust to certain changes. So the child is not able to adjust. So why? Mostly it is seen as IDD conditions. How are they expressed? Delayed milestones. The time particular crawling, rolling over, walking, standing, this doesn't happen. Poor academic performance, limited self-care ability. They are not aware of that. Now, this is just for example, common comorbidities is seen with ASD and epilepsy very frequently. So there are the 3 pointers that I've mentioned, explaining further also. Basically, early intervention can improve self-care and academic outcomes. Very sweet child. I think you guys can see it. Yeah. So we know the subtypes. Mild IDD, moderate IDD, severe IDD, and profound IDD. So when you enter this classification or this condition, the first thing you have to know is the IQ should be less than 70. That is the mild IDD category starting. So they have slower cognitive development and can live independently with minimal support. Now, the second one, we move on to the moderate IDD, where the IQ is 35 to 49, where there is limited academic skills, need moderate support. Severe IQ goes to 20 to 34, major developmental delays are seen, and limited communication skills. And when there's profound IDD, we see less than IQ 20, and extensive care is needed, and minimal verbal skills are noticed in these children. Now, autism spectrum disorder. So the core features, I know Dr. Rekha ma'am has completed this 4 session on this ASD month of September, but I have just covered. She has done beautiful sessions. Gem of knowledge has been passed on to you all. Just a concise form. That's all I could do within this bird's eye view factor. Now, core features are impairments in social communication and interaction, restricted and repetitive behaviorism interests, and sensory processing abnormalities. How do they show? They have difficulty in interpreting emotions. Okay, they prefer routines, and they're very hypersensitive to sound and light. Common comorbidities, they occur with ADHD, anxiety, and sleep conditions. So basically, it's a triad. You understand the triad. They have a social communication problem, you have a restrictive interest, and we have a repetitive action. We can doubt whether it be a child, whether it be an adult, there is he or she falls under the spectrum. Because it is a high heterogeneous species, whether non-verbal child to very highly functional adults, ASD can be seen. Actually, I've done a presentation on this for adult ASD, where we have explained about the masking that the adults do, because they are unaware of it, that they are suffering from this ASD. So they are very good in masking, they're very good in acting, but they are, because they feel that is normal. That's the only way they can survive. So that's why, but they're very high functioning adults. ASD children and people are very highly functioning, very high intelligent people. The brain shows reduced long range connectivity. What long range? Prefrontal to temporal and connectivity, but increased local hyperconnectivity can be seen. Okay. Now it is classified in a tabular form. So 2 classification I have mentioned: DSM-4 disorder and DSM-5 category in the extreme left and right. What we usually have followed was autistic disorder, Asperger's syndrome, childhood disintegrated disorder, pervasive developmental disorder, not otherwise specified. Categories were mentioned under DSM-4 disorder. But DSM-5 category, they have changed, like autistic disorder is under the umbrella term of ASD. Asperger's syndrome is also now under it because it is mild end. Now, CDD is now under ASD with loss of skills, and PDD-NOS is ASD unspecified category. Whether language delay is there? Yes, autistic disorder is showing a language delay. And childhood disintegrative disorder, once the disintegration starts, regression starts, they start showing the language delay. But Asperger's and PDD-NOS, they don't show language delay. Now, but PDD sometimes variable is there, like it depends upon the severity of the condition. Cognitive delay often in autism. Asperger doesn't show. CDD is severe. PDD-NOS is variable. Regression in autism is possible. Asperger is not there. Child, because it's usually CDD starts after 2 years of age. After that, you can see the regression happening very much. And PDD-NOS sometimes. The key feature ASD is early onset, classic triad. Asperger's are mainly social awkwardness with focused interest. CDD, normal early development, the parent, there's no problem. But after 2 years, you start to see the sudden regression. And PDD is otherwise also known as atypical autism, right? We move on to the next slide. ADHD. Now, this in particular, I'll be taking in the next session on November 11th in detail. So I've just kept it small. Basically, inattention. You can't point or diagnose any child who is having inattention, because ADHD, of late, the children who are addicted to the mobiles are also mimic the ADHD symptoms. So we have to be very careful while diagnosing and putting a term on that child. So, but there is inattention, careless mistakes, easily distracted. There is fidgeting and restlessness. There is impulsivity. They'll be interrupting you or acting without thinking. These all things will be there. Now, there is cognitive behavior manifestation. How? Short attention span. It's difficulty in sustaining that attention, interest in something. There's poor self-regulation. It is commonly seen along with oppositional defiant disorders. Basically, you can see teenage stuff in a very milder way. I'm trying to tell you for you to see the picture. ODD is basically when the child is so defiant that they will not listen anything. They have a lot of anger issues, but it has to be more than 1 year for you to diagnose. It is consistent. That's no matter any intervention is not going to bring any change. That is ODD for you. Now, that is also seen in ADHD. Confusion will happen during the teenage times. Then there is anxiety or depression also. Basic reason is there is an imbalance in dopaminergic and noradrenergic signaling, poor inhibition and sustained attention. Often persists into adulthood with, you just imagine, you can't even imagine planning for an ADHD adult. It will be a very difficult task for them to do. But they train themselves. That is another thing. They will train it. But that is their journey. Otherwise, it's very difficult for them to plan, and then very bad emotional regulation for them. They can't control they're very abrupt. They'll be like, in Hindi we say, "Muh pe bol dete." Like they'll be in front, they'll be talking to you on your face. Now the classification. Subtype is predominantly inattentive type, predominantly hyperactive impulsive type, and combined type. Very simple. So when they're very inattentive type, as the term explains, they have difficulty in sustaining attention, they have forgetfulness, they have disorganization. Hyperactivity, same like how the term explains. Excessive motor activity, there is fidgetity, inability to stay still, impulsive actions are there. Now, combined, both the criteria are met. Now come communication disorders. Core features are problems with speech language or social use of communication. How does the child show? They have delayed speech or limited vocabulary, very difficulty in understanding verbal cues. Common SLD and ASD, we can see comorbid conditions. Now, this I'm explaining the next slide, but still that is basically categorized into language, speech, and pragmatic communication disorder. The point to be remembered is it basically affects the left hemisphere underactivation. Why? Because usually the left is used for all the language specific zone. Okay, classification: language disorder, speech sound disorder, childhood onset fluency disorder, that is stuttering, social or pragmatic communication disorder. Language disorder is persistent difficulties in acquisition and use of language across the modalities, whether spoken, whether written, whether signed. Usually onset is early childhood. Now, speech and sound is difficulty in producing speech sound correctly, like articulation errors will be same, like 2 to 4 years when the child has started to speak, right? So that time. Now, this fluency disorder, the disturbance in the speech fluency and time patterning, there is repetitions and prolongations. The time typical onset is 2 to 7 years. Please do understand this stuttering should not be confused with the normal stuttering the child does when they're learning to speak, right? That any child who is having stuttering when they're learning to speak do not come directly under this fluency disorder, because that is their learning, but there's no struggle. They're trying to find out the word, they're trying to feel and explain it. So that is totally different. Stuttering can also happen due to anxiety. Adults have anxiety or performance anxiety. So these things are, and people who are already suffering from anxiety condition will also have stuttering. Those are totally, completely different with this fluency disorder. Okay. Now, the last part is the social communication disorder. There is difficulty with social use of verbal and non-verbal communication. Example takes turn in conversation. Typical onset is 4 to 5 years. Now, SLD, the core feature are persistent difficulty in reading, writing, or mathematics. Performance below expected level despite the child having normal IQ, unlike IDD. Now, the cognitive behavioral manifestation, dyslexia, reading, dysgraphia, writing, dyscalculia, math impairment, and common comorbidities, ADHD, anxiety, and low self-esteem. This has been covered by under learning disorders series by Dr. Anuparani ma'am, and I think the month of October. Wonderfully covered. So you don't need much explanation to be done into this. Still, it's again, like I mentioned, it's not at all due to low intelligence, but due to impaired neural circuitry for reading, left temporoparietal cortex. But children usually compensate with the right hemisphere. Now, this is where neuroplasticity comes. Okay, when the brain is able to adapt, right? The brain is able to adapt. It's getting weakened in the left, but now it is able to do it by overcompensating the right side. You see in the stroke also. So this neuroplasticity is the plus point, which is there. Now, I'm not saying this, I'm talking about the brain per se, where the neuroplasticity can be beautifully seen for the adaptive stuff. Now, early phonological awareness and training improves the outcome. Classification subtypes are dyslexia, dysgraphia, dyscalculia. We know what it is. Dyslexia means they have problem in reading inaccuracy, fluency, comprehension deficits. Dysgraphia, grammar, punctuation, clarity, spelling errors, and math. I think math is weak for almost every science. So, but it's not that level of mathematical difficulty that we are talking here. It's like totally difficult in understanding numbers and operation, how it happens and why it is done in that particular way. Now, motor disorders. This is a disorder which we'll see in which shouldn't be confused with neurodegenerative disorders. Okay, so there that motor disorder is completely different. That is, regression is happening. Now here, this motor disorder is a coordination stuff. Okay, so now the core features are deficits in motor coordination of repetitive movements. It can include tics, stereotypies, or clumsiness. How do they show? Poor handwriting, dropping the objects, clumsiness. They can hold together. It's not because they want. It's not a conscious. It's an involuntary stuff. Okay, so repetitive gestures or movements. It should not be confused with that of the flapping that we see under the ASD. You know, repetitive flapping will be seen, stimming of the term. That is different from this, because this is an involuntary action. There is also involuntary, but here it is more to the motor relation, motor background is there. So common is ADHD, anxiety, or OCD in Tourette's. So it is further divided into 3 classification: developmental coordination disorder, stereotypic movement disorder, and tic disorders. What are that? The DCD is impairment in acquisition and execution of coordinated motor skills. That is not only they have difficulty in acquisition of the stuff, but whatever the transmission of action is to be done, that also cannot be executed properly. So what happens? The brain is asking you to carry something. It's not, first and foremost, it is not received properly. Neither it has been executed properly. You make it also clumsy. Slow handwriting, poor sports ability. Now, stereotypic movement disorder is, like I mentioned previously, repetitive, apparently purposeful motor behavior like hand flapping, head banging, often seen with IDD or ASD also. Tic disorders, the Tourette's disorder, this small video clip I'll show you. Sudden, rapid, recurrent movements or vocalizations are there. Multiple motor plus one vocal tic for more than a year as Tourette's. So you can see the children here are like blinking and like, you know, they're having this tic sort of reaction. Yeah. So the epilepsy related NDDs, see, the typical neurodevelopment signs, early onset epilepsy that this, wait a second. In clinical neurodevelopmental signs, early onset epilepsies that disrupt the development are called epilepsy-related NDD or developmental epileptic encephalopathies. That means, like I said, epilepsy is usually neurological in origin, which is categorized under that. But in clinical practice, we do see epilepsy. There are certain early onset epilepsies that disrupt the development of the starting stages. So that is now trying to categorize it separately. So what are the core features? The core features are co-occurrence of, it should not only be the seizure, there should be a co-occurrence of developmental delay. And there is cognitive regression or language loss after the onset of the seizures. Now there is fluctuating attention, there is cognitive slowing is seen, the behavior changes are post-seizure. Now, like common comorbidities are with ASD and IDD. some genetic epilepsies, example KMT2E mutation syndrome. This is their particular condition where this gene mutation causes this neurodevelopmental condition. This directly impairs the brain development. So this is the starting point why this research had happened. Now, the cognitive decline can appear after the seizure onset, that is regressive encephalopathy, and requires, like I had first had mentioned, if you doctors remember, it's like it cannot be only the neurodevelopmental therapy going on. Obviously, we'll have to go for anti-seizure therapy also. So now, in short, if I say it is, I have tried to put it because there was no subtype that we can mention as such. It's a syndrome-based subtype that I could have made a tabular form, where these particular syndromes are there, which has linked towards the NDD associations. We can see that these particular syndromes are very much under study and under research for the neurodevelopmental aspects rather than purely neurological aspects. Okay, so like whether it be West syndrome, Lennox-Gastaut syndrome, Dravet syndrome, CDKL5 deficiency disorder, Rett syndrome, tuberculosis sclerosis complex, Angelman syndrome, epileptic encephalopathy with continuous spike wave. The onsets have also been mentioned here. So the age 3 to 12 months, 1 to 8 years in perspective. This is a tabular form which you need to read by yourself to understand, because each syndrome I have given the core features, like clusters of spasms happening for infantile stuff. For Lennox-LGS, multiple seizure types are there, slow spike and wave, EEG cognitive decline. So these core features are simultaneously associated with the NDD associations. Okay. So now this I'll be skipping because we are running short of time, I believe. So this can be read at your leisure. Yeah, so this is a tabular form, which everything I have tried to put it as a takeaway for you. So the left one category, core features, which I am not discussing right now. The only thing that I'll be discussing right now for time being is the key neuro mechanism is abnormal neuronal migration. Then microdeletion syndromes, example 22q11.2, and synaptic protein defects. We know Down syndrome and Fragile X syndrome. ASD, there is altered cortical connectivity, synaptic pruning abnormality. What is synaptic pruning? Basically, at the age of 2 years, the child's synapses are like millions out there. Most of them are active, but most of them are not used. So what the brain does, they start to cut off. That is what is synaptic pruning. Okay, the synapses are getting pruned away. Now, some abnormality is happening, the issue arises. Got it? Now, ADHD is having the, this I have mentioned before also. Now, the communication disorder are impaired neural plasticity in Broca's and Wernicke's area. One is language production, others language comprehension. Broca's language production, Wernicke's language comprehension. Together they form the learning network. And there some neural impaired plasticity is happening. There is language disorder, stuttering, pragmatic communication disorder. SLD, left temporoparietal underactivation, altered white matter tracts, arcuate fasciculosis. That is the connection that has between the Broca and Wernicke.
I think the line is a little interrupted, Dr. Jagati.
Just a second. I think it's Dr. Shalini's problem. Here it's okay. We can see others, no?
Yes, I was just checking that.
Please,
I think
please call her. Shalini ma'am, you please call her. She may not be knowing.
I think she has left and she might join again.
She has left the meeting, I think. She'll be coming back.
Yeah, she's left the meeting. She'll join. Sorry for the inconvenience, everyone. Please stay with us.
Yes, I think I got disconnected out here.
Yes, doctor, we have you back.
I'm sorry, I was totally unaware that I'm off. Yeah,
No problem.
yes. Hello. So we move on to this one. So, begin early life in, yeah. So we begin early in life, the condition, and often, let's get the group back. Okay. Then they involve disrupted neural connectivity and synaptic signaling is common thread across all entities. That is frequently co-occur with each other. Basically, they like to go in groups, like ASD plus ADHD, IDD plus epilepsy, and lifelong conditions, but modifiable with early personalized intervention. Diagnosis. So I'm trying to run fast here. So this integrate DSM-5-TR, whatever the table I'm going to present to you, and recent most 2024 or 2025 evidence from frontiers in psychiatry, Nature reviews, neurology, and epilepsy and behavior. So this is common for everything, but let's go. When a patient or a child, when the parent comes to you, so these are the left side are the stages that we have to follow. First, screening, clinical evaluation, functional assessment, etiological workup, comorbidity evaluation. Why do we do screening? So basically to identify the developmental risk. What are the key components that we look? We check about the developmental milestones, we check about behavioral checklists, teacher parents reports, because the child per se is not able to speak and communicate well. So we go with what the teacher is saying, we go with what the parents are saying, right? Now the clinical evaluation to confirm the diagnosis. Key components, neuropsychological assessment, DSM-5 and ICD-11 criteria. There's a huge criteria list is there, which I'm sure you have gone through that during the session with Dr. Lekha ma'am and Dr. Anparani ma'am. Now, the functional assessment, you determine the severity and the adaptive level, right? So how do we know that? Like cognitive, social, communication, motor, and daily living skills. So this how much level or what severity level is the child functioning, that we determine, or that is assessed. Etiological workup, we find the underlying cause. How? Genetic testing, there's no other way. MRI, EEG, metabolic panels, right? Now the comorbidity evaluation, what all things are there? Whether it's not only what NDDs, there are other conditions also can be there. Whether psychiatric conditions are there, whether other medical conditions are also there for the child. So based on that, we give the total protocol. Now let's the diagnosis is for the Kellogg. Now diagnosis, yeah, it's coming up. Okay. Particular wise, I have listed that is for intellectual developmental disorder. You know the clinical criteria. So now what are the tools? These are the tools, Wechsler intelligence scales, Vineland adaptive behavioral scales, which has to be supported with the genetic testing, microarray fragile life for fragile lives, and MRI brain. The standard stuff which have to be followed, which is easily available. And it is being followed. That is the only way we can get it done. ASD, we have autism diagnostic observation schedule, autism diagnostic interview revised, and childhood autism rating scale. EEG is done to rule out epilepsy, which is sometimes mostly it occur with ASD. And now neurology epilepsy, which that talking about this neurological epilepsy. Okay. Now MRI for cortical anomalies. Now ADHD, we have Connell's 4th edition rating scales, Vanderbilt ADHD diagnostic rating scale, continuous performance test. EEG and ERP. What is ERP? Event related potential. for attention variability and neuroimaging for results. What does that happen? You have put the electrodes, EEG machine is running, and the patient or the child is showing the stimulus, sound. How the EEG variations are having, how waves are being changed, that is being recorded. That is the event-related potential. For ADHD, it is very drastic. The communication disorders, we have self-5, Goldman-Festos test for articulation, P-body picture vocabulary test. Also, hearing assessment and speech-language evaluation. For SLD, we have Woodcock-Johnson 4, Wechsler Individual Achievement Test, Dyslexia Screening Test. We have to take MRI for a typical language network and psychometric evaluation. Motor disorders, movement ABC, that is assessment battery for children. Yale Global for 6 severity scale for Tourette's. And now the neurological examination is basically a proper pakka stuff that has to be done. And MRI for cerebral imaging has to be done. Okay, there has no escape further. But it should be supported. We say that all imaging has to be supported with the clinical assessments. Epilepsy is seizure diaries has to be managed. EEG, developmental screening, Bailey scales has followed. So here epilepsy, genetic epilepsy panels are also done. Treatment modalities, again, bird's eye view. We can't go in depth. There are 6 approaches actually that I'll be discussing in short. See, NDDs are neurobiological but behaviorally expressed. Hence, diagnosis depends on objective behavioral scales and biological corroboration. It's very, it is something which we are aware of. We are just putting words to what we know, right? It's a multidisciplinary assessment. You cannot just expect one doctor to sit and do it. Or any NDDs, any ASD, whether ADHD, any particular condition, it is a multidisciplinary approach. You have to have a psychiatrist, you have to have a neurologist, you have to have a psychologist, speech special educator. We have a speech therapist. Maybe furthermore, therapists or a department need to be called in for the proper diagnosis of this condition. The early diagnosis is equal to better neuroplastic recovery. Unsaid stuff. Now, treatment goals. Sans few conditions, prognosis can be handled by early diagnosis. Now, treatment goals are important daily functioning, improve the daily functioning, enhance adaptive skills, reduce behavioral distress, and support caregivers. Actually, the biggest thing is to support caregivers because it takes immense patience from the end of caregivers towards this child. Because the child, fortunately, I would say, is unaware of the trouble the child is giving to the caregivers. So who has to be at the upper hand is the caregiver whose morale has to be constantly boosted. They have to be constantly motivated. They have to be constantly guided towards the actions that has been done. So like I said, with more to the pharmacological approach, this is purely the allopathic approach or English or mainstream conventional medicine approach that you would like to, that I have mentioned here. Because it is a neurobiological, neurochemical change imbalance. So the focus area is to balance it out. These are the stimulants for ADHD, for ASD irritability water medicine, for epilepsy, for anxiety, depression, comorbidities. These are the medical group, medicine groups that they go for. Applicable disorders are usually, see, these are the examples, strictly not limited to it. So ADHD, ASD, epilepsy, comorbid anxiety. Now, this we have to go with the homeopathic, behavioral and cognitive therapies. Modify the behavior and enhance the coping. What are the interventions that we do? CBT, cognitive behavioral therapy, applied behavioral analysis, management training, and mindfulness-based interventions. These are the applicable disorders. Now, educational and skill-based intervention, again, homeopathy. Along with homeopathy, we have to do this. The focus area is academic and adaptive improvement. For example, like you give individualized education plans has to be intervened. Speech and occupational therapy the child has to undergo. There should be multi-sensory teaching has to be go, especially for dyslexia and all. So SLD, communication disorders, IDD and all, we can follow it. Now, neurophysiological therapies, what comes? It improves the brain connectivity. These are like neurofeedback, EEG-based self-regulation, transcranial magnetic stimulation. So under trials, it is basically for ADHD and ASD is under trial. Experimentation is going, experimental stage is going on for this. Now the family and social support, I mentioned before also, we need immense family and social support. It's basically to promote the social adaptation. See, we can't keep them out. Yeah, we have to create a safe place for them to evolve and flourish and thrive and reach their potential in their own way, in their own pace. So what we as a society who's running fast, maybe sometimes has to enjoy the slowness, enjoy the patience, enjoy the have the strength to carry forward or look after the children of these type. So how to do it? To motivate, to have them promote social adaptation. So that is family psychoeducation is important. Peer social skills training is important. And group therapy, yeah, is important. So applicable disorder is like ADHD, ASD, and IDD. Digital and AI, these are the emerging 20 therapies that I have found out, which is interesting for today's times. It's very much interesting because cognitive enhancement and monitoring is a prime aim through AI-based cognitive games. So through this
The
specific,
slide didn't change.
okay, just a second. Now, is it moving? Should I stop sharing and restart?
It didn't move.
Okay, just a second. I will restart again. Okay. Is it now clear? Can you see? Yeah.
It's still, yes. You can try,
Okay,
Dr.
now.
moving the slide.
Is it fine? Is it moving?
Yeah. Go on.
Yeah.
Yes. Yes.
Yes. Okay. Okay. Yeah. Good. So I have explained about this AI-based cognitive. Yes, AI-based cognitive games. VR for social training and wearables for attention tracking. Basically, it's for monitoring, right? So, like who needs monitoring for attention? ADHD, onset. Also for ASD and for SLD, whether they are following it up. That is important. Now, these are the emerging trends, not only for the treatment, but also for diagnostic. There's AI assisted. See, AI is now everywhere, to be very honest, fastly moving stuff. The more we are aware of this, the more we are into this AI system. No matter what you want to say, it is going to take over. So we have to be up to the mark, understanding the diagnostic tools, which is fair enough in a very positive manner it's moving into, as far as I'm concerned. So AI assisted diagnostic tools, which is integrating the MRI, the EEG, and behavioral data for precision phenotyping. There is epigenetic biomarkers also, like the blood methylation signatures predicting the ASD and ADHD risk factors, who all can be there. Gene therapy for targeted trials for Rett syndrome, MECP2 and SHANK3. There is a targeted gene therapy is going on. So all different researches are there, which is all together a huge science and a huge study is going on behind it. Now there is digital therapeutics. This is a new one. See, we have app for everything. So this is this FDA approved app-based ADHD training. If the child is or the parent they are unable to come, you are like, this is an example app that I found where you download it and you can have the training via the app. So it's improving, it's changing in a good manner. Now comes our homeopathic approach. We all of us know homeopathy, how it is done. Dr. Shahina has already explained in the beginning itself, basically how homeopathy works. We all are very well aware. Still, I have to explain. So here it is, constitutional remedy based on child's totality, mental, physical, genetic, and miasmatic. There are intercurrent remedies must be given. Tuberculinum, mostly no source. Medorinum, carcinosum, to clear the miasmatic blocks, which will be seen. There will be supportive remedies, like when this particular regression is happening, or aggression is happening. So hellebore is for regression, stramonium for aggression. Irrespective of these supportive remedies, if the child is falling sick, is having any condition, cold, cough, fever, diarrhea, constipation, these things has also to be considered, and the treatment should go on. You should not ask, you take one dose of antibiotic. No. You have to give our own medicines along with these medicines. This is the basic, but in between. So supportive medicine for me, that also comes. And there is a regular follow-up. Without that, it's no way we can go, because this whole group is a very slow but deep improvement seen homeopathic approach when it's added to it in a right manner. Can be seen whether in the cognitive as well as social skill. But like we say, it is not something which is happening, something which is accepted. No. We have a lot of tug of war going on between the accepted formats, but of late, we are moving very fast with respect to this stream of conditions where our homeopathic medicines have shown tremendous benefits. So now this is, I've divided the miasm, the medicines that can come, and what all the symptoms that we can find under the miasm for the particular NDDs. Yes? So the medicine's name I'm not going to read. We all know what most of the medicines that comes under the SORA miasm. Now, what all conditions that we are giving which falls under the SORIC is like where there is mild developmental delays are happening. The child is timid or shy personality, poor stamina, anxiety, sensitivity to environment, sounds, and slow comprehension, withdrawn but not destructive. Now there is psychotic, there is hyperactivity. Psychotic is like hyperactivity, impulsivity, repetitive acts, poor inhibition, clinging behavior. So these medicines are given. Now syphilitic, there is regression. Destruction is happening. So loss of acquired. What all I have learned, I've lost. Destructive is the basic thing. Self-harming acts, violent tantrums, cognitive deterioration, seizures, convulsive disorders, and tics, rigidity. These medicines. Now tubercular, alternative progress and regression. The changeability is there in tubercular miasm. There is marked restlessness, quick learning, then sudden loss, sensory hyperresponsiveness, anxiety, temperamental variability. Now, a few other miasms we know: cancerogenic miasm, sauropsychotic mixed miasm, psychosyphilitic destructive plus impulsive, and pseudosoric or tuberculosyphilitic deep mixed miasm. So under this miasm also here, we see carcinosin murinol. Carcinosin, apart from nosode, it is a very good constitutional medicine also, provided the personal experience, provided the constitution and the totality of the symptoms agree. So there's high intelligence with inhibition. There's perfectionism, excessive emotional control. So they are perfectionists, so we can understand. So trauma-induced regression, OCD-like rituals, affectionate but internally they are violent. Now, sauropsychotic is like alternating moods, mild impulsiveness, clinginess, emotional stability. That's psychosyphilitic when it comes. There's aggression, but fear-driven violence. Sexual precocity, but erratic motor behavior. So these combinations are there. Like tantrums are also there. Violent tantrums are also there. Psychotic-like tendencies are there. Then for pseudosoric, there is periodic deterioration, alternating calm and extreme aggression. Then regression after illness. Convulsions, loss of milestones, and emotional extremes. Now, I'm not going to read about the remedies which are commonly indicated, but the symptoms and the feature. The child is showing speech delay or aphasia. Good remedies we know. Varitekar immediately comes in our mind. Hyperactivity or impulsivity. Tarantula, agaricus, medoranum, that should jump in our mind. Emotional withdrawal, that's autism core syndrome. Carcinosin, Varitekar, Silesia, Helleborus. There is regression happening also. Aggression, stramonium is the first thing which will come. Hyoscyamus is there. See, these remedies are not limited. There are many. So I've just put on examples. There are repetitive behaviors. We have carcinosin, Medorina has repetition. Okay. Now, Nacardium has repetition. Regression, the loss of skills are happening. Helleborus, Bufo, Syphilinum because it is destructive. Epileptic or seizure, again Bufo will come. Cicuta is very good. Now, sensory processing issue, whether it be hyper, whether it be hypo. Agaricus, phosphorus, carcinism. Fear, night terrors, anxiety, stramonium, belladonna, ars, calcarea. Now, restlessness with destruction, tuberculinum, tarantula, medorinum, and stramonium. Let me be very honest, this picture is just for an idea, the potency. It will vary depending on the vitality of the patient. But for general, we can say if it is early or mild ASD or ADHD or speech delay, like we can give 200. 1M is only for constitutional if we are able to come to it. Okay, please do not jump into 1M immediately. And if it is 200, it will be 15 to 30 days. Okay, or whenever the relapse is happening. Now, if it is moderate or regression or sensory, go for 30 to 200. 2 to 3 times a week initially. For severe condition, always better to start 6C, 30C, 12C. Low in infrequent. LM1 can be started daily. When vitality is low on multiple medication with epileptic, better to start slow with the low potencies. Okay, once daily for 7 to 10 days, review the response. But there is high vitality and we have clear picture. We can go 1M, 10M also if you are so sure. but LM is one preferred one because we can monitor it. We can teach the parent to move on to LM1 to LM2. It's a slow change, but it is quite effective. The aggravation, the regression, or the aggression can be under control. The gentle stimulation. These are the references. I'm at the end. So, as Larry Prusak said, knowledge is in groups, not individuals. I may fall short. You may be having more knowledge. It's always about sharing. And with sharing only we will learn. It's a wonderful platform. Thank you once again for inviting me. It's been a pleasure, and I hope you also learned a lot as much as I enjoyed explaining it, and in a way of teaching whatever I know in a very concise and compact and crunched up manner. Thank you so much.
Dr. Salini, you kept us glued to your learning.
Thank you so much.
The technical glitch, our lovely audience remained still with us while you went away.
Wow.
Thank you so much, Dr. Salini, for making me feel calm with I am calm.
I am calm.
I still have to memorize your mnemonics, but I have taken a lot of screenshots of whatever I was learning today. And what a comprehensive, insightful session, full of clarity, compassion, and thorough brush up of all theoretical takeaways. I'm sure all of us are leaving with a deeper understanding of neurodevelopmental disorders, especially ADHD, and how we as practitioners, parents, and educators can contribute meaningfully. And as an observant homeopath, I love the henna on your hands.
Good.
Engrossed in sharing your wisdom.
I do that. That's a way learning takes for me, and explaining it keeps something is occupying you.
So you kept me glued in different ways.
It's a pleasure. Yes, sure. I'll just send across this presentation to the group so that we can use it.
That's so lovely. That's so kind of you. So it's time for learning more in the question and answer session. I now invite all the audience to share your questions in the chat box so that Dr. Salini can help us know a little better. If you have any questions, please type in the chat box and I can ask Dr. Salini to help us.
And also, I would like to speak in here. Like, if at all you don't have anything right now, please go through the presentation that I'll be sending, because there are a few slides which I couldn't explain in depth. So after that also, I am okay to give an explanation. That's the same WhatsApp number or the email ID I can also share. If you want to take time. Because it's a big topic.
There are a few questions. I'll start sharing and you can answer for the audience. Dr. Thomas has SLD below expected low IQ. Is it correct? SLD in children must have normal IQ, otherwise they cannot be diagnosed as SLD.
Yes. See, when the normal IQ goes below 20, it is under IDD. Because SLD is usually, they don't have any IQ issues. Much. Okay, but like this is the specific one I'm saying. But we have overlapping conditions. No particular, like I said, it moves in groups. So if the child is having SLD along with low IQ, then there is IDD somewhere down the lane. Got it? We can't, unless and until it has not been diagnosed, we cannot say, okay, because SLD, it's purely SLD. So the child is having less than 20, so it cannot be SLD. There is no strict norms around that because overlapping. Otherwise, SLD is the child is having normal IQ. Yeah, can I see the questions also, because I'm more like, can I open the chat box so I can?
Yes, Doctor, you can.
Yes. So, because I usually go with the
Dyslexia is not an alternative for reading. Disability and dyscalculia is not an alternative term for mathematics disability.
Yes, it can be. See, I have used a very vague term in so that people can understand what exactly is. So terminology wise, I have not gone through. But we usually say dyslexia is when the child is not able to read properly. Right? The words are getting confused. Okay. But On a larger screen, I have put that word. If you want it, I can change it into the presentation. But for better understanding, I've written like that. Next. Is it mute? Dr. Shahina, your audio is mute.
Someone has muted me. Okay.
Yeah.
Is it MRI or fMRI for SLD diagnosis?
See, basically, it is fMRI, but you do first go with MRI, right? We first move on to that, and then when we have a doubt, we can go into alternative MRIs that can be done. Okay, fMRI will be moving on. Yeah. Now,
Right. The next question is how to deal with dyslexic children. Dr. Bibi Asfa asks us how to deal with dyslexic children.
like see, dyslexia need, like we said, we have a training has to be done. If you have mentioned, if you're seeing my slide, I'll share you once again here, if you may.
Okay.
Yeah.
How to take the rubrics or medicine where mother has a fear during pregnancy or
No.
mother's emotional state during pregnancy.
Yes. Can I just read this first? Then I'll reach there.
Yeah.
Just a second. I think somewhere I have mentioned. Yeah. Here. So when we intervene, there is multi-sensory teaching, where there is Orton Gillingham for dyslexia. This is a nice. You saw that, right? You have seen that, whichever doctor has mentioned this. So this is a sort of methodology, training, or intervention that we can give for dyslexia. See, dyslexia, again, it has to be slow. It has to be speech therapy also has to be introduced. Learning has also to be introduced. It's a slow process where the child has to assess, the assessment has to be given to the child, where along with the assessment sheet, along with the training, and improvement is slow, but not, its progress is not bad. Clear? Am I clear? Is that doubt clear to the doctor? Bibi?
Dr. Bibi, are you clear? Okay. I think she was muted.
Can I add on one more point?
Yes,
What
please.
I notice is that when we give medication for learning disability children, whatever if a therapy alone is given, the child will not improve enough fast. But when we are giving a medication, their cognitive or their ability to perceive or ability to retrieve and all is improving. So reading capability is improving and sustaining better than therapy alone. When we are giving remedial classes, remedial training, special education, we are giving that alone, the child will take longer time. But when medicine is also given, it improves the speed. This is what I felt. Ma'am, am I right?
Dr. Salini, you would like to add? Dr. Salini?
I think she has some problem with the,
I
she's
think
gone
we
out
are-
of the group right now.
Yeah. Dr.
You
Halloween,
may
can
join
you
again.
She
She'll
did
join
so.
again.
Okay. Because last time she did not come to know that she's out.
I'll message.
Yeah. Meanwhile, we have Dr. Salini join in. If there are any senior homeopaths who would like to share their knowledge on ADHD.
Sorry, I'm so sorry. My phone got switched off. I have to go through everything again. I'm so sorry. Yes, yes. Okay. I'm so sorry. Let's start. Where were we?
So I think the doctor.
Bibi Fatima, Bibi Asma's, you answered her question, doctor.
You already
Yes,
answered.
okay.
And she
Okay,
thanked
so
you.
I was
Yeah.
talking, oh, I'm so sorry. And I was answering this rubrics by doctor about maternal. So I didn't realize because it was stuck. So I thought it was going on. And I apologize. So what was the question? So she
Dr.
is there.
Renu has a question. Yeah, I think
the
Dr.
chat.
Renu has
My
had a
question was, may I ask the question?
Yes,
Yes,
please.
My
please.
question,
Yes, please.
yeah, my question was, if the mother is facing during her pregnancy, if the mother is facing a fear, or if she has some emotional issues during pregnancy, how will we take that symptom in the child? What will be the rubric, or what should be our perspective
Oh,
in
very
taking
nice.
that symptom?
Very interesting thing. I'll have to think this over, to be very honest, Dr. Ramya, because fear in mother, we can go with mind fear. Okay, now you're talking about the child who is having who's had mother having the fear, right? So I would have to go with the totality. I'm sorry, I can't help you right now in this aspect. So if any other doctor who can give me a suggestion on that, I will also learn with that. Which rubric can go with that? For mind, mother's mind fear, we can go with mind fear during pregnancy. So any other doctor who can let me also know rather than we opening the repertory right now and trying to find it.
Okay, meanwhile, we get the answer to that. Dr. Divya Shri has a question. Anything about vocations for these kids?
Yeah. See, actually, do you know Chef Vikas is a very prominent Michelin restaurant Vikas chef from India. He's having one staff. She is having Down syndrome. Okay, he considers her sister. What I'm trying to say is the vocation, in especially if you say whatever modeling, chef cooking, managing, all they need is a push. Vocation is for everybody, what the heart desire, what the child desire. It is basically for the mild variant for the NDDs children, but for the major one, we have to go. It's quite difficult for them to get used to their social adaptability. But when the child is mild and moderate, we can go for anything that they want, whether they want to become an artist. Because if you say down the line, most of the children are able to work along with the normal staff with patients. There are many cafes that have been opened by these IDD children and their family, and their many children are in the modeling phases also. So it all depends upon their vocational interest. Is it clear?
Then Dr. Divyashi, I hope Dr. Salini has answered your question.
Are there right now? I'm just having this. What will be the
questions? Yes, Dr. Divyashi says yes. We have answered her questions.
Thank you. No, I just am finding representation that Dr. Ramya had asked, because otherwise I won't be able to sleep. So let's start with that. She wanted fear of child when mother had fear, right? I think I didn't understand the question again.
Yes, ma'am. I have heard many classes also. We have heard that the pregnancy complications, no, the eugenics is affecting the child. So
yeah, definitely.
many case, yeah, they will be telling like as the mother has faced this medicine comes like that.
Agree.
So I just wanted
agree.
to know. Yes.
Yes.
Gradually you
Jamshina.
tell. No hurry. You can put it in the chat or anything will do. No hurry.
Yes.
Dr. Jamshina has suggested mind anxiety pregnancy during.
Yes, that is what I was saying. That was I said, for that mind anxiety, pregnancy during is fine. But I think Dr. Ramya was saying about the child, right? For the child, we have to take.
Correct. Yeah.
Yes.
So that's what I got. That was the first thing I was saying for mind. We can go with mind fear also during pregnancy. Huh, Kentler? We can go there also. And
Yes.
anxiety during pregnancy, that also is there. So maybe I was not able to comprehend your question. I apologize for that because I thought I have to look at it from the child's perspective.
Ma'am, I understood.
Okay, glad. I'm happy. And thank you, Dr. Milan Jyoti, for
We are
inputting.
also regarding mind anxiety.
Yeah,
So I
yeah.
think,
Huh.
we don't have any more questions at present.
Mhm.
You have answered all our questions.
Actually, we should thank you for such an elaborate description. The medicines also, or the
Thank you.
miasms, everything you have mentioned. We should go and learn it once again and find out. And then only question comes.
Oh, but okay. It was nice knowing questions also. But like I do apologize to Dr. Ramya because I didn't understand her question. I was thinking in the wrong line. Because whenever the repetization happens, I personally need to be in a zone where I take full totality. So it doesn't come tip of my fingers. I have to sit, I have to understand which points I have to take. So when it came, I was thinking from the child's perspective rather than what she actually asked, which is what I thought.
No, many times I too take like that. But
Ah.
I have heard in many cases doctors telling like the mother was facing this, so this was taken.
Hmm.
So I just wanted to know that. That is
Basically, it is a safer thing is what we usually take. Fear or anxiety, whatever she's telling, during pregnancy. That is the thing. Even when we are giving for child. Unless and until there is something specific we have mentioned.
Thank you so much, Dr. Salini. And to bring this wonderful session to a graceful close, I now invite Dr. Vinita to deliver the vote of thanks. Dr. Vinita is the face of our homeopaths and our all-time inspiration in UAE. She is a distinguished senior-most practitioner with over 35 years of experience in the holistic healing. She is currently practicing at Al Birra Clinic. Dr. Vinita, over to you.
Thank you. Thank you, Dr. Shaina, for your introduction. I just completed 40 years of practice this year. So now we can put it at 40 years.
I try to gather your years, but then you so young that we put it as at 35.
And it was a really wonderful lecture. Thank you, Dr. Salini. And as Dr. Shaina said, the very fact people stayed back even after you had left, waiting for you to come back, says it all, you know. But yes, it was very interesting. And really, we appreciate your giving the recording. And because we really have to see it 1 or 2 times to really benefit from all the knowledge that you have given us. Definitely, I'll be going through the thing while I'm free, because definitely, I mean, there's so much more we can learn from this, what we would have missed because of the time and it was so much information coming up.
Yes.
You know, so it was really, really grateful for that. It was so informating, you know, the diagnostic tools, the treatment plan, the miasms, everything you covered up. And also, what I found interesting was your little mention of mobile addiction. And I think that's one topic we have to pursue. And I think there's a lot of research going on. I was at another conference the other day where there was a top person talking about de-addiction of mobile as we do de-addiction of alcoholism and substance abuse, which I found very fascinating. He was a psychologist talking. So, like when you spoke of and I thought it was very true and practical when we see and so much cases being put as ADHD when actually it's the mobile addiction, because the mother is sitting with the mobile, the father is sitting with the mobile, and the child is sitting with the mobile. You know, it's like that. But thank you so much for a very informative session. And we look forward to much more learning from you in future also. And of course, thank you, IHMA, for your wonderful sessions. Thank you, Dr. Halloween, Dr. Shahina, Dr. Rajshri, Dr. Devshri, all of you for this wonderful session. Thank you.
Thank you, ma'am.
always her word, which is the final word for homeopathics over here. So thank you so much for being present today. And with that, we conclude today's webinar. A big thank you to our speaker, our respectable moderator, the organizing team of IHMA National Women's Wing, and each one of you who joined us this evening. Until we meet again in our next session, can we all put our videos on to capture this moment of learning? Dr. Jagati, you can take a shot while we all are present over here.
Just a second.
Can we all put our videos on? We are capturing this moment. I think we all are on.
Yeah, done.
Yes. None?
Yeah.
Thank you so much. Stay inspired, stay connected, and keep spreading awareness. This is Dr. Shaina signing off with gratitude and good wishes to all. Have a lovely week.